Fibroid. Fibroid is a smooth muscle tumor of uterus, and it is the most common pelvic tumor in females. Um, so, how does this fibroid develop? The pathogenesis of fibroid says there are actually many ways that a fibroid can develop, but most common are by two means. First, if there is a normal myocyte, it can undergo transformation to form an abnormal myocyte, which will grow into a tumor. So the transformation from normal myocyte to abnormal myocyte is helped by that transformation process is being helped by somatic mutation and fumarate hydratase. And in somatic mutation, the most common somatic mutation is MED12 somatic mutation. MED12 is a mediator subunit complex, and the second most common somatic mutation is AT hook. So in the somatic mutation, first most common will be MED12, second most common is AT hook, and the other factor that helps in transformation of normal to abnormal myocyte is fumarate hydratase, which is an inherited mutation that helps in formation of hereditary leiomyomatosis. So, if fumarate hydratase is involved in transformation of normal to abnormal myocyte, there will be upregulation of estrogen receptors, upregulation of aromatase receptors, and progesterone receptors will also be upregulated. This progesterone will inhibit the apoptosis, and the vascular abnormality that helps in formation of fibroid will be increase in angiogenic growth factors. And the fibrotic process that helps in formation of fibroid will be upregulation of collagen. So to recall the pathogenesis of fibroid, a normal myocyte should undergo transformation to form an abnormal myocyte, and that abnormal myocyte will grow into a tumor. The transformation from normal to abnormal myocyte is being helped by somatic mutations and fumarate hydratase. And the most common somatic mutation is MED12, which is a mediator subunit complex. The second most common somatic mutation is AT hook, and fumarate hydratase is another factor that helps in transformation of normal to abnormal myocyte. So fumarate hydratase is an inherited mutation. Fumarate hydratase causes hereditary leiomyomatosis. So the other factors which helps in pathogenesis of fibroid is upregulation of estrogen receptors, upregulation of aromatase receptors, upregulation of progesterone receptors, and progesterone will inhibit the apoptosis. And the vascular abnormality seen in the vascular abnormality that helps in formation of fibroid will be increase in angiogenic growth factors, and the fibrotic process that helps in formation of fibroid will be upregulation of collagen. And the risk factors of fibroid include early menarche, late menopause, nulliparity, black race, obesity, alcohol, and diet that is rich in red meat, and diet which is deficient in vitamin D as well as in vitamin A. So these are some of the risk factors which will favor fibroid. The protective factors will be smoking and multiparity. So regarding the types of fibroid, there are actually three types of fibroid: intramural, subserosal, and submucosal. Intramural is the most common type of fibroid, and submucosal is the least common type of fibroid. So all the fibroids will begin with intramural type. So next is Figo classification. So here types 0, 1, 2 are submucosal. Types 3 and 4 will be intramural. Type 5, 6, 7 will be subserosal. Type 8 will be cervical. So type 0 fibroid is completely intracavitary, that is it will be a stalk. And type 1 fibroid, it will be more than 50% intracavitary. Type 2 fibroid is less than 50% will be intracavitary. In type 3 fibroid, it will be intramural but it will touch the mucosa. Type 4 fibroid will be pedunculated subserosal. So to recall again, type 0 is completely intracavitary, that is it will be a stalk. Type 1 more than 50% is intracavitary. Type 2 less than 50% is intracavitary. Type 3 intramural but touches the mucosa. Type 4 pedunculated subserosal. So here types 0 and 1 can be removed hysteroscopically. Type 0 cannot be removed hysteroscopically. So the clinical presentation of fibroid will be mostly asymptomatic. The most common presentation of fibroid will be asymptomatic. So asymptomatic means there will be no symptoms, but if we do USG, especially in women more than 35 years, 50% of the women will have fibroids. And this is regarding the asymptomatic category, that is they'll show up only in USG. So in case of a symptomatic fibroid, the most common symptom will be menorrhagia. Menorrhagia means heavy menstrual bleeding, but there will be no irregular bleeding. So menorrhagia is the most common symptom. So that fibroid which can cause irregular bleeding is type 0 fibroid. Type 0 fibroid is the one which causes irregular bleeding. So first there will be venous congestion in the fibroid, which will lead to necrosis of mucosa, and then ultimately it will cause bleeding. The cause of heavy menstrual bleeding is abnormal vasculature, impaired endometrial hemostasis, altered myometrial contractility, molecular dysregulation of angiogenic factors. So to recall the cause of heavy menstrual bleed, the causes for heavy menstrual bleeding in fibroid will be, the first is abnormal vasculature, next is impaired endometrial hemostasis, next is altered myometrial contractility, the next is molecular dysregulation of the angiogenic factors. So which fibroid most commonly causes H&B? For this question the answer is submucosal fibroid. Submucosal fibroid is the most common type of fibroid which will cause heavy menstrual bleed, and the most symptomatic fibroid is also submucosal fibroid. So if the female is symptomatic, the most common symptom will be menorrhagia, and the other symptoms will be pain, then degeneration, that is most commonly hyaline degeneration, then pressure, dysmenorrhea, infertility, recurrent pregnancy loss, and endocrine side effects. These will be the other symptoms. So regarding pain, the causes of pain in fibroid will be pressure, degeneration, torsion, and most commonly the pain is seen in subserosal type of fibroid. Pedunculated subserosal fibroids will undergo torsion most commonly. So the most common fibroid to undergo torsion will be pedunculated subserosal type of fibroid. And regarding degeneration, the fibroid will enlarge and it will start to degenerate from the center. Exception will be calcific degeneration, because the calcific degeneration, the degeneration will start from periphery, and this calcific degeneration is most commonly seen with subserosal fibroid. So there will be a warm stone appearance. So most common degeneration in fibroid will be hyaline degeneration. Least common will be sarcomatous change. This sarcomatous change is a rare malignant change, less than 0.5%. Postmenopausal female plus enlarging fibroid plus pain. If all these three are present, then it indicates a sarcomatous change. And regarding the red degeneration, hyaline degeneration is the most common degeneration in fibroid, but this red degeneration is specific to pregnancy, especially in second trimester of the pregnancy. Red degeneration means it will cause local tenderness in the area of the fibroid. The red degeneration will present as acute abdomen pain, nausea, vomiting, fever may or may not be present. The investigation which will be done in case of red degeneration is neutrophilia. There will be aseptic neutrophilia, and if there's red degeneration present in pregnancy, we have to first keep the patient NPO, nil per oral, and we have to give just conservative treatment. That is, we have to first give NPO and then IV fluids and analgesics and antipyretics. The next symptom will be pressure. This pressure, especially if there's a pressure due to fibroid, mostly it will be urinary. Patient will present with urinary symptoms. So if there is an anterior wall fibroid, there will be increase in frequency of the urine. If there is a posterior wall fibroid, there will be acute retention of the urine. The posterior wall fibroid will enlarge and it will hit on the POD, that is pouch of Douglas, and it will push rest of the uterus forward. So there will be obstruction of the outflow tract. So it will cause, the posterior wall fibroids will cause acute retention of urine. The next symptom will be dysmenorrhea. Dysmenorrhea will be present in fibroid, but it will never be a chief complaint. The cause for this dysmenorrhea will be heavy menstrual bleed, but there will be no dyspareunia. There will be dysmenorrhea but no dyspareunia. Infertility and recurrent pregnancy loss are most commonly seen with submucosal fibroids. So if a woman presents with fibroid during pregnancy plus fibroid, then it can cause the fibroid during pregnancy can cause preterm labor, intrauterine growth restriction, abruption, malpresentation, postpartum hemorrhage. Then endocrine effects of fibroid will be polycythemia, hypercalcemia, hyperprolactinemia. The investigation done in fibroid will be TVS, transvaginal sonography. So small submucous fibroids can be missed on transvaginal sonography. So therefore the saline infusion sonography is superior than transvaginal sonography. MRI is not done routinely. In some patients, the MRI is done preoperatively to plan the surgical procedure. On HSG, submucosal fibroid can be picked up. So in HSG, the submucosal fibroid will present as a smooth filling defect close to the boundary of the wall. And the DD of fibroid will be polyp and adenomyosis. So treatment of fibroid. So if it is an asymptomatic fibroid, no treatment will be done. If the woman is a perimenopausal woman and she has asymptomatic fibroid, then also no treatment is done. If she is a pregnant female, if the patient is a female who desires pregnancy and asymptomatic, no treatment is done, but there is an exception. There are two exceptions for this condition, that is a female who wants family but with asymptomatic fibroid. There is no treatment done except for two conditions, that is in case of submucosal fibroid and bilateral corneal intramural fibroid. In submucosal fibroid, hysteroscopic myomectomy is done. In bilateral corneal intramural fibroid, laparoscopic myomectomy is done. So, if a patient has symptomatic fibroid, then we have to treat. So the most common symptom will be heavy. So the treatment will be symptomatic treatment only. So mainly the woman will present with heavy menstrual bleed and pain, pressure, etc. So if the patient presents with heavy menstrual bleed, we have to check if it is type 0, which type, we'll have to find out which type it is. So type 0 and 1 fibroids, the treatment of choice will be hysteroscopic myomectomy. For other fibroids, we have to do medical management. And in medical management, first line will be OCPs, Tranexa, Mirena. These three will be the first line drugs given for heavy menstrual bleed in fibroid. OCPs are the drug of choice in fibroid. So this first line drugs, that is OCP, Tranexa, Mirena, they will not decrease the size of fibroid, but they will decrease the bleeding. If there is no response to these first line drugs, we'll have to move on to second line drugs, that is GnRH agonist or GnRH antagonist. and we'll have to administer this continuously. Second line drugs will be continuous administration of GnRH agonist and antagonist. The preferred drug will be elagolix, ELAGOLIX, elagolix. If there's no response to the second line drugs, then we'll have to move on to third line, that is uterine artery embolization or MRGHIFU, which stands for magnetic resonance guided high intensity focused USG. So this third line treatment, that is uterine artery embolization or MRGHIFU, is done only when family is complete. So even after doing this third line, if there is no response, then the last resort will be myomectomy or hysterectomy. So if the patient desires baby, we'll have to go to myomectomy, and if family is complete, we'll have to do hysterectomy. And the other symptom which the patient can present with will be pain, pressure, etc. So if the patient has pressure due to fibroid and if the patient wants to conceive, then we can do myomectomy. If the patient does not want to conceive, then we can give GnRH agonist or antagonist to decrease the size of the fibroid, and then we can if there's no response to this GnRH agonist antagonist, we can go for uterine artery embolization or HIFU, that is high intensity focused USG, and then if there's no response to this treatment, then we can go for myomectomy, hysterectomy. Myomectomy for those who want to conceive, hysterectomy for those who don't want to conceive further.